So we have a few questions that are already there. The first one, maybe for you, Angela, why do we not have a genetic profile for each of the JAK inhibitors? It says in all the clinical trials, there is always a minority who respond well. The companies have collected genetic panels and could do an analysis to show which patients do well and which do not based on specific mutation patterns. What are your thoughts about this question?
Yes, that's a very important point. You're nicely identifying that it probably would be most important to do an ad hoc, like a post analysis, because moving, as prospectively, it'd be difficult to really enroll only specific patients with specific mutations, but sort of after the fact, go back and see who really responded well, who didn't, what mutations they had. Yes, and I think that yes, that's something that is usually done with the small number of patients that have specific mutations. It's difficult to make any definitive conclusions, but as you emphasized, probably the best approach would be to conglomerate data from multiple clinical trials from multiple different companies to identify if there are, I guess you could say, any trends. But I guess the only thing that we could identify realistically would be trends based on the N of patients with each specific profile.
That's great, thank you. We have another question by someone who didn't identify himself in the poll. So maybe if you want to have your CMA credit, please remember to put your name and identify yourself. So the question is, if ruxolitinib can sometimes cause anemia, would it make sense to change JAK inhibitors or when possibly adding luspatercept? I mean, the question here is, what would be your preference or which patients should deserve an add-on with a drug, a symptomatic drug such as luspatercept versus switching for momelotinib or pacritinib, for example, to resolve anemia in these patients?
Yeah, I agree. And I think maybe what the person is getting at is, why would you add, if somebody's getting anemia from ruxolitinib, why would you just add on luspatercept? Why wouldn't you switch the JAK inhibitor? Potentially the patient, if they've been on ruxolitinib for a while and is really enjoying good symptom relief and spleen response and is liking the medication, potentially they would not want to change to a different JAK inhibitor that could potentially, not address their spleen and symptoms as well, and maybe have a different sphere of adverse effects.
Okay, yes, this makes sense. I mean, we should either think to add on something because we have sometimes a good response besides anemia on other parameters, and it's important. You didn't mention, Angela, the ongoing phase 3 trial with luspatercept called Independence, and we have a question about that. What are your recommendations for referring patients for enrollment into the phase 3 Independence study, luspatercept versus placebo, in subjects with MPN-associated myelofibrosis?
Can you repeat that question? I don't quite understand.
Yeah, well, maybe I can reformulate that in another way. What are you showed nicely that in the phase 2 trial of luspatercept, the best responses was achieved in patients transfusion independent, but also on ruxolitinib. Do you have any ideas of why in this particular subtype of patients, and why in combination with ruxolitinib more than, transfusion dependent patients only?
I mean, it could be, on one thing that I'm always curious about is what it could, does that demonstrate that luspatercept is just sort of reversing an adverse event of ruxolitinib, meaning it's sort of you're reversing a side effect, rather than necessarily getting it to the root of the problem. I don't know whether I'm specifically answering your question, but I think luspatercept might be most appropriate in people with who have coincident SF3B1 mutations who have anemia with ring sideroblasts. That might be the specific patient population in which luspatercept is particularly beneficial.
That's great. Yeah, very nice. Thank you. Well, we have a question or maybe a comment by an MPN advocate, Werner Zinkand, asking, would it help to develop a guideline when to use which inhibitor? I think you nicely made some suggestion, but why don't we have such guidelines? I may say, for example, for Europe, because you said that you have the 4 JAK inhibitors available in the US. It's not the case still in Europe. We have 3 of them approved for the moment, and momelotinib was the most recent one, but pacritinib is not approved yet, so it's different for us here. But do you think that we should propose some guidelines about that?
I think that the NCCN guidelines have sort of a rough, a rough guidelines of what to choose. I think the patient population who's anemic and thrombocytopenic, there you have you can choose at least in the US, choose upfront momelotinib or pacritinib if their platelets are less than 50. But I think each patient is unique, so I don't think that it would be beneficial to have strict guidelines. Also in the US, there may be issues in terms of which drug is on formulary for their particular insurance. So that also may guide selection of a JAK inhibitor for a specific patient.
I think you're perfectly right. There's such a large heterogeneity in the presentation of patients. Some of them complain more of spleen, others from constitutional symptoms, others for anemia. So it's clear that we need to have a kind of comprehensive view of all the needs of each individual patients, and maybe to come back to the first question by Ned at the beginning, maybe also include for if we have some clues in the future, the molecular profile, the mutational profile of patients, and this will help us probably to choose the best JAK inhibitor, at least first line, and then discuss in case of no response or loss of response. We also have a question about interferon alpha. It's true that we didn't mention this drug. Maybe I can start answering to that. Is there a place for interferon alpha therapy in patients with anemic myelofibrosis? To answer that question, we published several years ago a retrospective study of the French patients who received interferon alpha, showing that indeed we could have nice responses on anemia to interferon alpha therapy in myelofibrosis, but only in early stages of the disease. And one, I think, very practical finding of this study was that, for example, just the spleen size, if the spleen size was more but then 7 centimeters by palpations, we had almost no response to interferon alpha therapy. So this was a very simple parameter that could help, to find which patients could benefit of interferon alpha therapy, showing also reinforcing the earlier findings by Dr. Silver and his group that low-dose interferon alpha therapy was able to reverse the bone marrow fibrosis in some patients when it was not very advanced. In grade 3 fibrosis, it's too late. But if you have grade 1, grade 2 fibrosis, then you may observe nice responses to interferon alpha therapy. Do you have any thoughts, Angela, about interferon in MF?
I think you answered it quite comprehensively. We're sorry we didn't go over interferon on the slide deck. I think it's a very unique agent in myelofibrosis or in myeloproliferative neoplasms in general, and really does have disease modification potential. I agree that probably it's best used in early myelofibrosis, or potentially from my standpoint, prior to them developing myelofibrosis. The ideal would be to intervene before myelofibrosis actually occurs to avoid that outcome.
That's a very important point, and the prospective evaluation of patients' status is very important. And for that, repeating sometimes the bone marrow biopsy, if you see some changes in the clinical or biological patterns of the patients, may help to start a therapy before it's too late, or make intervention to avoid disease progression. This is very important. Another question about luspatercept from Caroline Zolas. This probably the patients who was treated with luspatercept and reached more than 12-gram hemoglobin. So is there an upper threshold not to shoot over with any, of these anemia treating agents in patients with anemia?
So I think it sounds, with other agents that we use for anemia, like erythropoietin stimulating agents, there is a threshold. If you go over that threshold, then you stop it. So it seems to me that it's very, common sense to do the same thing for luspatercept. It sounds like this person, you got a great response to luspatercept, which is great. Yes, it would be very, very reasonable to stop, continue to monitor the hemoglobin, and then redose once the hemoglobin goes below 11. I mean, that sounds very, very reasonable.
This is mostly for the risk of thrombotic events, right?
Yes, I mean, with any medication, you have to weigh the risks versus the benefits, and it looks like this person has really gotten some nice benefits from the drug, and with a hemoglobin over 12, doing extremely well. So at that point, probably doesn't make sense to put them at risk of side effects with not much more to gain, because they've already achieved the desired response.
Excellent. We have a question from Gunnar Loh. How would you switch between JAK inhibitors? Would you sneak in or out, overlap? That's an interesting question, because we know, for example, that ruxolitinib discontinuation may be sometimes painful, with a rebound of symptoms, a rebound of splenomegaly that sometimes can be very difficult for the patients. So now that we have several JAK inhibitors, do you think that we should switch from one to the other, in one day to the other, overlap? What is your thought about that?
What I usually do is give the patient the option. My preference is to basically stop one JAK inhibitor on one day and then start the next JAK inhibitor on the other day, the day after. But I always propose two options in terms of doing the quick switch over one day versus the next, versus tapering off and then starting. Everybody's always chosen just stopping on one day and starting on the next. The question about overlapping, I don't know really it's bringing up, I know you're not asking this question, but it does bring up a curious other, area to think outside the box, is how about we combine JAK inhibitors, or potentially cycle JAK inhibitors, give somebody, a month's worth of ruxolitinib and then give them a different JAK inhibitor, and then sort of cycle. So every time they're sort of getting a fresh JAK inhibitor, which to my knowledge, I don't know if there ever have been any clinical trials looking at cycling between different JAK inhibitors or combining them. I don't know the rationale about combining them so much, but potentially, switching them at different frequencies might be interesting.
That's great. It shows that we still have many options to explore for these patients, not only a combination of a JAK inhibitor and another agent, but also between them, maybe sometimes could be interesting. That's a good question and completely open field.